We've got to be able to point people to the proper place to get the services that they need for their mental as well as physical well-being.
And once you provide that direct contact line that they may have with you, they start to feel more comfortable.
But people have to trust you first before they start sharing things that are sensitive to them. But we really found out very quickly that community health workers was definitely needed for a part of our team. They've been very helpful as far as getting us closer to our patients and being able to meet the patients where they are. So as you mentioned, they're not clinical, but they are very savvy. You can't be harried and you can't be rushed. And that's what makes it so good to have our community health workers on board.
For both rural and urban communities where the stakes are just too high. Like you get into a moment, you make a choice, and like there just shouldn't be the kind of consequences for one choice over another. And you know, if you're in a community with a lot of resources, then yeah, you get to try things again. Like you get to mess up and it's okay, and you're going to get the support you need. And that's kind of what we want to build for everybody.
It is that very good communication between the CHWs and the providers, because both of us together can tag team and give the patient the education and the resources that they need to complete what we're asking them to do.
Hi, everyone. I am Dominique Seck, and I am a program coordinator for Nevada Office of Minority Health and Equity, also known as NOMI. Welcome to Utilizing Community Health Workers in the Public Workforce. NOMI is a program within Nevada Department of Health and Human Services department. Our mission is to address health-related disparities that disproportionately impact our state's minority populations, identified by ability status, race, ethnicity, sexual orientation, and gender identity, and economic background. This purpose is translated through education, outreach, and advocacy to ensure that systemic vetting of health equity. So in honor of Minority Health Awareness Month, our office developed 5 events. This is the second one. And after this event, I will email our office's newsletter, which contains details about the remaining webinar, a vaccination clinic, and a health resource fair. Today's webinar will highlight the importance of community health workers to ensure the well-being of all Nevadans. We hope that you leave this webinar with a clear understanding of the CHW role, the various ways that they can be utilized, and how to become a certified CHW. And with no further ado, I will turn it over to Elisa, who is a public health servant, leader, and an owner of Minority Health Consultants. She will provide a brief overview of community health workers and how she became a CHW and CHW instructor, and then she will moderate a brief discussion among our panelists.
So I will introduce myself. My name is Elisa Howard. I am a community health worker and also a community health worker instructor for the past 4 years. I'm also the owner of Minority Health Consultants, where I work with stakeholders who have a vested interest in working with minority populations and marginalized populations to bring health equity and equality to those populations and those communities. I also sit on the National Community Health Worker Association Policy Board, part of the Community Health Worker Advisory Board here in Nevada. I'm a part of the Nevada Association of Community Health Workers, and I teach for the Nevada Community Health Worker Association as well. I believe in this work. And just to kind of jump right into how this work even came to Nevada, community health work has been done in other states for the past 30 years. States like Texas, Massachusetts, Rhode Island have had community health workers for the last 30 years. Nevada has only been knowing the name community health work for the past 6, but I didn't get involved until year 4. And unbeknownst to me, I had already been a community health worker by definition, and I had hired community health workers without even knowing it. I'm a former HIV AIDS director of a program called Minority Health Services at the Las Vegas Urban League, and I hired HIV navigators. And as we go through this presentation that I will give about community health workers, you will see how you may have already hired community health workers also, but you're just not using the title, or you may not know that you even have those people within your organization. And so there is a community health worker certificate that they can get by taking our class at the Nevada CHW Association. So I will get right into our presentation really quick about what is a community health worker. So the history of community health work, as I stated, here in the United States, we've been utilizing community health workers in other states back 30 years. But CHWs go back to the late 1800s in Russia, 1930s in China. There were more than 1 million CHWs in China from the 1950s to the 1970s. Promotores de Salud in 1973 in Mexico. And then in the United States, the largest system to formally use the skills of CHWs was established in 1968. The National Community Health Advisor Study estimated that there are actually more than 600 programs and at least 12,500 CHWs throughout the United States. And I'm sure that number has risen because this slide is about 2 years old. So this number has definitely risen. So other names, so just in case you are an organization out there listening, you may not know that you have community health workers working in your organization. These are some other names for community health workers: case managers, case workers, community health advocate, community health outreach worker, community liaison, community organizer, enrollment specialist for those that work in the insurance realm, health ambassador, health educator, patient navigator, peer counselor, educator. I bring that one up because that's a big one that we use in HIV, but also in substance misuse. And then promotora, and then public health aid. So those are just some of the names that community health workers go by. And just because you don't call them a community health worker, you may call them this other name, they're probably doing the duty of a community health worker. So what do CHWs do? We advocate. We are advocates. We are advocates for other people, for communities, for populations. We advocate through helping our clients, but we also advocate for their behalf. So if a client is going to a doctor's appointment or something of that nature, and they don't know how to speak up for themselves, I've heard this often in certain communities. They don't want to tell the doctor a certain thing, or like just tell them no. That's where we come in. We can advocate for our patients. We also advocate for bills. The CHW bill, actually AB 191, had a few community health workers advocate for it. We are case managers. We do community outreach. We do health education. We do home visits, just depending on what company you work for and the scope of work that you have. And then we do linkage to care. So linkage to care is a big term that we use in HIV, also in substance misuse, obviously, but it can be used in so many other realms in public health and also in community health. And that just means simply linking the patient or the client to the care that they need. We also can provide information and awareness on various topics regarding health and wellness. We provide referrals to community-based agencies, organizations, or other assistance. We support clients in assessing quality healthcare and social service programs. I have an example for that. One time I was working for a company called Access Health, and I had a client who actually needed to get to the Social Security office, but she said she's already been there and she did not get the help that she needed. So I met her there and I walked her through the paperwork that she needed to get done. So community health workers can also help in that way. And then we support other healthcare professionals, other social workers, in this access care model as well. That's where my example is coming from. Another company that was here that had community health workers a couple years ago, they actually had a support system. So they had a doctor, and then it would be a nurse, and then a social worker, and then a community health worker. And so we all worked as a interdisciplinary team. And so we would basically assist the social worker. One of the roles that we play, or we bridge the gap between communities and the health and social systems. That's one thing that I really like to highlight often, is that the community health worker is someone that comes from the actual community. They are a person that they already were doing the work, most likely, helping people, giving people referrals. Maybe they're that person for their family, whatever that is. That person is already probably a community health worker. They just need to be trained, get their certificate, and then they can have the official title. One thing that community health workers do is that we enhance care quality by aiding communication between provider and patient to clarify cultural practices. As we will see, Oprah has a show coming up talking about the health disparities across America, and how medical practices can be racist, and how there's a lot of racist systemic things that have gone on in medicine, and that will happen May 1st. So limitations of a CHW, because there are limitations. CHWs are not they're not a one-all shop. They can't do everything. And that's one thing that we'd like to emphasize. We are not the social worker. So all those social workers that are out there, we are not trying to take your job. We are there simply to support you. We're also there to support the physician, to support the nurses, and anyone else in a healthcare setting that may need our support. And then when we're not working in those settings, we're working in organizations or faith-based churches or faith-based organizations, which we'll talk about with Bishop Thomas on here. They will support in any other efforts that may come about. So just some limitations. We're not clinicians, and as an instructor for sure, let people know that we are not physicians, we are not doctors, we are not lawyers, and we are not social workers. Although I call us the referral ninjas, because we can find a referral as quickly as we can, and we know a lot of different community organizations and resources out there that other people may not know. We're still not the lawyer. We still cannot give legal advice. We cannot give medical advice. So I like to say that we are non-clinical CHWs most of the time. If you do work in a clinical section, you can work with doctors, but you are still not the doctor. And so the CHW profession is considered an entry-level job in the human services career field. No degree, certification, or license is required to be a CHW. Now, we don't require certification, but you do have to take a training to actually get that certificate, and then you can become certified if you so choose. And if your organization that you work for tells you that you need to become. And then CHW should never represent themselves as a clinician, doctor, social worker, lawyer, or any other profession in which a degree, certification, or license is required. And then lastly, CHWs may assist medical or health professionals, but need to keep in mind their role, which is connecting clients to resources, professionals, and other support systems. So with no further ado, I would like to get into this conversation, because there's lots of people on here that may want to hire community health workers and now be reimbursed by Medicaid for that from the AB 191 bill that just passed our last 81st legislation. Yes, it was 81st, 81st legislation session, which a couple of our panelists actually helped get that through. All right, so I would like to introduce our panelists. Today we have with us Bishop Ron Thomas. I also know that you are a doctor, so I never know to call you Dr. Bishop Ron Thomas. I also have Darylyn Lopez, who is a CHW and a CHW advisor. And then I have Ms. Deborah Toney. Both of them are from Nevada Healthcare Center. And then I have Jay, where are you? Are you on here? Yes. Jay Cobalt-Castle from the Nevada CHW Association. Thank you all for being here. And if we can just start with Bishop Ron Thomas. Bishop, you are a doctor as well. Could you just introduce yourself a little bit more and tell us a little bit more about you?
Yes, I want to say good morning to each and every one that's joining from the panel as well as in the community. We are a doctor of religious theology, and so we don't want to be facetious and say that we're a doctor in the medical field. We are a doctor as it pertains to helping people as it pertains to their soul and spirituality. We are bishop in the Church of the Lord Jesus Christ here, to serve our community for the last 26 years at Reconciliation Apostolic Ministries, and we're grateful for the opportunity to serve the community in the area of making sure that the medical field and the faith community comes together to work concerning a few things. And that's why this conversation is very important as we talk about community healthcare workers. And so I look forward to the conversation, Elisa.
And Jay, we come over to you. Can you introduce yourself a little bit more and tell us about the association?
Hello, so I'm Jay Colbert-Classell. I joined the association just over a year ago to work on more support for frontline workers. Prior to that, I mostly worked with the unsheltered community, and I have a master's in social work. I have 3 kids, and I'm between Dayton and South Reno.
So you are in our northern part of Nevada.
Yeah, northern Nevada. And then a little bit about the association. So the association started in the north near Carson City, because the capital wasn't really ready to start their own association. And the Healthy Communities Coalition was just about a 15-minute drive, and they were able to host. They believed in the CHW model and had quite a few CHWs on staff. And so that's kind of the history of how the association landed at at this particular nonprofit. And in the long run, just teaming up and using both of our skills and their administrative capacity has just been a really good fit. And so we've kept the association with the Healthy Communities Coalition in Dayton.
Perfect. Thank you so much. And Ms. Deborah Toney, Dr. Deborah Toney, can you please introduce yourself a little bit more and what you do for Nevada Health Centers?
Good morning, and thank you so much for having me here with you today. I'm Deborah Toney. I am a nurse. I am the Vice President of Quality Management at Nevada Health Centers, and community health workers have been a member of my team since I guess probably around 2014, 2015. So Nevada Health Centers has a long history. We are the state's largest federally qualified community health center. We have 18 locations. We provide services to everyone. So whether that is the homeless population, mobile units, primary care, dental, behavioral health. So I think I'll just kind of leave it right there because I could go on and on. So thank you so much.
Thank you, Ms. Toney. And Ms. Darylyn Lopez, you can introduce yourself and tell us what you do for Nevada Health Centers.
Good morning, everyone. My name is Darlene Lopez, and I am currently the Navigation Care Coordinator here for Nevada Health Centers. I've been a CHW for about 5 years now. I did start at our Martin Luther King location, now currently at our Henderson location. I'm trying to educate and assist our patients with any barriers that they may have in completing their health screenings. Thank you.
And thank you for the work that you all do. All right, so let's get into this discussion. I'm sure everyone is just ready to hear what you all do in this field and how you all use community health workers. So Dr. Toney, when did Nevada Health Centers begin working with CHWs? I think you kind of answered that a little bit, but can you give us a little bit more information?
We started working with community health workers in 2015, where we had a collaboration and a grant with the state of Nevada to bring in community health workers to increase the screening rates for colorectal cancer screening, as well as women's health, which has to do with PAPs and mammograms. And we have kept community health workers on board with our staff. While we still have a grant for women's health, we don't have a grant for colorectal cancer. But we really found out very quickly that community health workers was definitely needed for a part of our team. They've been very helpful as far as getting us closer to our patients and being able to meet the patients where they are. Again, when we start looking at cultural and linguistic care, that's been helpful because they are members of the community. But again, a lot of the things you talked about as far as outreach, education, but we also use them to help us close the care gaps. So reaching out to patients, whether it's mammography screening, and as an FQHC, we have several measures, clinical quality measures that we keep up with. So as you mentioned, they're not clinical, but they are very savvy as far as we have a blood pressure program. So being able to train and teach patients and educate patients on their blood pressure monitoring, screenings, et cetera. So this has really been, I guess I'm going to say, a big feather in Nevada's hat once they started taking a look at the new legislative bill, which I think has really created a lot of buzz throughout the state to be able to help offset some of the finances I'm sure we all associated with providing this additional service. So they work very closely with our clinical team, not as a medical assistant, but as a community health worker, and be able to do warm handoffs for our practice team. So our providers, our physicians can do what physicians do, medical assistants can do what medical assistants do, and now our community health workers do what community health workers do. And Darlene will get into more of those. She talked just a little bit, but Darlene, I would say, is our lead community health worker. She is excellent. She knows exactly how to make it happen.
Thank you, Ms. Toney. You brought up a couple of great points that community health workers can be trained in other health education segments, right? Hypertension, they can be used for diabetes education. And that is one thing that we would like to highlight here. Community health workers are for what you need them for as far as an organization is concerned, right? You just train them on what it is that you would like them to go and work with the community on. And so thank you for bringing that up.
We
And
actually use them in our PrEP program, our HIV linkage to care, our HIV PrEP program. So we use them in a lot of different capacities.
So happy to hear that. You know, HIV is near and dear to my heart. So thank you for doing that, Ms. Deborah. Darylyn, since she brought you up, can you kind of segue into what she was speaking of how you utilize your community health workers there?
Yes. So like how she mentioned, we did start with the Women's Health Grant, and we did start that. I personally started that at MLK, and it was hard at first for sure, because you have a lot of the providers not really understanding your role, or the MAs. But once they got to feel and know that you're actually there to assist them when you have positive results, or you are having a hard time trying to contact the other location sites and get these medical records, and the MAs don't have that kind of time to sit here and stay on top of it, or call a location multiple times because they're failing to send us the information in a stat manner, since the patient may be here or that's the reason for their visit. So once they actually found or were accepting of us that we actually can assist them, they were all on board. They actually did like it. They appreciated it. And as a team member, knowing that you can bring something to the table to where you can take something off of a provider or an MA where you have a little bit more time to do it, it feels great. Because they acknowledge it, and they are, like I said, very grateful for it. And not only for them, it's also for the patients, because we don't want to have to have the patient sit here while you're struggling to get all these medical records, and then the patient's just sitting there 10, 15, 20 minutes go by. It's always to be prepared so we can look very professional once the patients come in, and we don't look like we don't have it together. But it is great, and I think that they've so far appreciated for sure.
Thank you. You brought up a great point. You said that once the patient gets to know who we are and they're accepting of us, I think that's so important for people to realize, because it is a new thing in Nevada per se. There's not a lot of people who know what a community health worker is, right? So when you tell them your title, hi, I'm a community health worker, sometimes we get that resistance and that pushback. How many visits do you think it takes for someone to get used to working with that community health worker?
Personally, I want to say maybe 2 to 3 times, because like you say, that first time you're sitting there, you're either screening them for whatever it may be, you know, blood pressure, women's health, colorectal. And once they'll be hesitant, you'll give them the information, you give them the kit. But once they see that you can follow up, and once you provide that direct contact line that they may have with you, they start to feel more comfortable. So at that point, it may not just become about their screening. Now they're contacting you because it's easier to get a hold of you for medical prescriptions or for appointments, because, you know, they don't want to go through the call center. So at some point they do contact us for more than just being the community health worker. So it does take a few visits for sure.
About the cultural representation, right, that you represent for them, right? I really like to highlight that sometimes it's the connection happens because they see them in you, right? They see you as the same cultural, having the same cultural experiences, but also maybe the same race. And so representation is important in public health and working in healthcare settings. And I just would like to segue into that, working with Jay at the Nevada CHW Association. How important is it to have representatives from each community working in community health work?
I mean, that's a huge question. And I'll just start by saying we're still a segregated society. So if you're going to reach everybody, you got to go where people are. And I think that's a #1 reason why we need more broad recruitment in health work, and why we need to make sure that it's an equitable environment so that people can thrive and grow into those positions. The importance of community health work is it's just such a great segue into public health. Somebody can, you know, they have a strong connection to their community, and community health work provides just enough education to kind of get them into the care team and help them, you know, join that ladder and access the opportunities that should be available to them.
Absolutely. And we thank you for your leadership at the Nevada CHW Association, Jay. Since you've been there the last year, have you seen different communities be served at a higher rate than they were before?
Absolutely. So in overall, we've had a huge increase in the number of students. And on top of that, by percentage, we've had an increase in African-American students from 13% to 25%. And I see that number is actually quite a bit higher because I started tracking that in June when the health disparity grant started from the CDC. And within a few months, we really saw many more students from African-American communities join. One area where we still haven't seen the growth that's necessary in order to serve everyone in Nevada is with Asian Americans and also Native American groups. So Native American tribal authorities do have CHW programs. They are not new to the work, but they do deserve more funding and support to reach the same level of service that we see in other demographics.
I'm so glad that you brought that up. I was thinking about that the other day when you showed a slide with the numbers of representatives from community health work as far as in these different populations. And so our Asian American friends and our Native American friends, we would love to have more people representing that community. So if you are interested in taking a community health worker class, please get on the Nevada CHW Association's website and sign up. But also, if you're an organization on here representing those communities or you work with those populations, please contact us and let us know, because we would love to just spread this out throughout Nevada so that each community is getting exactly what they need. And so with that, thank you, Jay. With that, Bishop Ron, I want to bring you into the conversation. What are you doing with community health workers in the Black faith-based community?
Well, thank you, Elisa. As you know, I'm here because we're the chairman of the Nevada Faith and Health Coalition. I serve in a double dynamic. Number one is serving a predominantly African-American congregation, but also the other demographic is the faith community. You know, and so when you start talking about the faith community, access to care, specifically as it pertains to the stigma that's associated with HIV and AIDS, and the stigma that's associated with mental health issues, you know, we have found, you know, that in order to get people access to care, and COVID has exposed that tremendously, there has to be a couple of things. Number one, there has to be a trusted source. And so that's where, as you and Jay mentioned earlier, and also Dr. Tony, having cultural competency, having a person that looks like you and someone that, you know, speaks your language and someone that understands, you know, you on a personal level, being able to assist you getting access to care. What we've done is we've become a licensed community healthcare worker ourselves to understand the course, you know, understand the process. I've learned so much in that particular process. And the word is, once again, and I think you've mentioned it, becoming an advocate for everything from our seniors, you know, to an advocate to a person that is a young, you know, male that just doesn't go to the doctor. You know, once again, COVID has exposed, you know, from culturally, some of the stigma that's associated with the trust issues with our African-American community and the medical community. So what we're trying to do here from the coalition standpoint is to make sure that we work along with you and Jay's agency to, number one, get our community trained. And that's number one. And then more specifically, try to provide a trained, competent individual that can be responsible for assisting the faith leader, you know, with managing the health affairs of his congregation. Specifically in the area of HIV and AIDS, if a pastor, is he aware of anyone in his congregation that is struggling with that particular disease? Does that person feel comfortable or, you know, sharing that information with that spiritual leader? Does the pastor know someone in his congregation that's really struggling, you know, with a mental health issue? And does he have access to be able to point that person in the right direction to get the right proper care? And so my responsibility, you know, is to make sure that just because you're a spiritual leader and we believe in God and we, you know, biblical, you know, scriptures, we've got to be able to point people to the proper place to get the services that they need for their mental as well as physical well-being. And so this conversation is broad, like you said, Jay, and it's dynamic. And I'm just glad that we're here at the table to be able to discuss it.
Thank you so much, Bishop Thomas. You are one of the faith-based leaders that we go to now in public health because we see that you're open. You have obviously not a religious mindset, but you have a holistic mindset, right? You know about religion, but you also know about spirituality. And you don't let that stop you from learning about public health. And so I've been in public health for 10 years. I'm sure there's a lot of people out there that's been in public health for a while. And we can honestly say that it's been hard working with Black churches and just with some faith-based organizations in general, not necessarily just Black, because of the difference in what maybe the scripture says, what we actually need to get done and help people. How do you bridge that gap between the spirituality and the religious aspect of what, some people would think, like for HIV, some pastors have told me that they don't want to talk about HIV in their pulpit because you have to then address sex. And we don't want to address sex in the church and things of that nature. How do you bridge that gap?
Well, two things, Elisa. Number one, going through the training myself, I learned something, and we have to be able to do that as spiritual leaders. We got to put ourselves in an environment to learn. There's something that we teach and we learn called implicit biases. Everyone has their own bias and their purview from which they look through a lens. And we have to make sure that our biases, don't impede our opportunity and position to help others where they are. Everybody that comes to my church doesn't have the same level of spirituality, understanding of scripture, socioeconomic backgrounds or whatever. And I can't treat them from the way I'm looking at their circumstances. I have to meet people where they are. And so once again, that's where the whole cultural competency comes in. That's where, providing excellent training through this particular programs and getting them into the organizations so that we can meet people where they are and bring them to a level of care, get them access to care. And last but not least, give ministries a go-to person so that the pastor, in his ability to provide spiritual counseling and all that, he has access to information that is not in his dynamic or purview as it pertains to the medical field and medical community. I was shocked and did not realize the advances as it pertains to, and not to make this an HIV issue, but when you start talking about the advances in technology in the area of medications to assist individuals that are living and suffering with that disease, we as a faith community need to make sure that we're sharing that with our young people, because once again, the African American community is well aware of the impact that this specific disease is having, not just on its male population, but on our female population. And we need to make sure as a faith community, we're getting people the information needed to stop this epidemic.
Absolutely. Thank you so much for that. As I go talk with Ms. Deborah, I want to bring you back into the conversation as well and segue into what Bishop Thomas was talking about as far as meeting people where they are and then that religious aspect. Have you had patients in the work that you've done? I know you've been there for like 20 years. Have you had patients that have said, my religious belief is not to have, something done or this surgery done or something of that nature? And how do you handle that?
One of the things, and I wrote it down here, Bishop said, and I think we all have to recognize is that people have to trust you. So just because we are a healthcare facility, of course, I believe we have the best and most talented providers and teams in Nevada, but people have to trust you first before they start sharing things that are sensitive to them, especially at Nevada Health Center, because we are, funded through HRSA. There are a lot of things that we have to ask patients in order for us to provide holistic care. So when you start talking about things like whether it's HIV questions, if it's things regarding gender, transgender, just a whole host of things, race and ethnicity, with all the you know, with all the volume and all the issues that are surrounding sexual matters, things, the racial turmoil that we're experiencing now, what we find is that patients get afraid and they don't want to answer those type of questions, but them not answering those questions can be very detrimental to the future and the quality of their life. So we have to just really, if they say it's religion and that type of thing, that always kind of, you know, takes you back a little bit because you don't want to be intrusive. But we take the approach that, you know, this is why we're asking those questions, and you can't be harried and you can't be rushed. And that's what makes it so good to have our community health workers on board, because they now can come in and they can explain it in a manner. We all know when you go to the doctor's office, you're not going to be in the room for 2 hours, you know. So there's a lot of other individuals that you may come in contact with besides the provider, the nurses, MAs. But now that we have our community health workers, they can get into those deeper conversations, and we talk about that, and they get the type of training that they need for buzzwords and that type of thing that may come back, you know, that patients may ask. But trust, it doesn't matter. We have to think about all of the education and the material that's out there on Twitter, Facebook. We know when patients come to see us that they've done a whole bunch of research. They already know, and there's a lot of talk now is how do you make that material more credible? Because that's where people are going to go first. Then they will say, well, I think I better go to the doctor. And then they're going to tell you, well, you know, I've done my research. So again, not telling them that, you know, that's not true, but really meeting them where they are and giving them the opportunity to ask us questions and where do they want us to fit into their lives as healthcare professionals.
Absolutely. You said a couple of things there. You're absolutely right. People are into their own research. We saw that during COVID,
Yes.
right now, during COVID as well too, right? We had a hard time as public health workers and healthcare workers getting people to understand about COVID and wearing a mask and social distancing because they've done their own research. So how do you combat that? Let's go with Darlene. How do you combat that as a CHW? How do you bring the correct information into the conversation after someone's told you that they've done their research?
All we've done so far is just provide them with the correct information, which is what we've get from the CDCs or any of the handouts. And when we still see that they're still hesitant, just bring it up to your provider. There's nobody else who's going to give you the wrong information. Your provider's not going to trick you into completing something. They're the ones who you should be asking to have any questions answered. When we still see that they are still struggling, we've just give them the information. And then at that point, I just communicate with the provider and I say, listen, this is the patient. They still don't seem like they're interested. Can you go in there and see what you can do on your end? And sometimes, not a lot of the times, the provider will go in there, discuss their case with them, and then they'll come back and say, you know what, they do want that screening. So go ahead and go back in there, explain what they need to do at this point. And the patients at that point seem a little bit more relieved because I think it's their healthcare provider giving them the information because, you know, Google has a lot of stuff out there that probably is 95% incorrect, or you start freaking out and you don't want this, or you see some symptoms and you're like, oh my God, I have that. And then it's completely not even, it's nothing. And so it is that very good communication between the CHWs and the providers, because both of us together can tag team and give the patient the education and the resources that they need to complete what we're asking them to do.
And we do give them that opportunity, Alicia, back to what you originally asked about, is who is the person that they trust? Is that their minister, their pastor? Is that a close family member? Is it a good friend? So, you know, we can always offer them, well, why don't you talk to, who is the person that you trust that you can perhaps talk to, and then come back and we can talk about that just a little bit more. But just a whole litany of individuals that they feel that they can trust.
Right, a lot of individuals, I see Jay, a lot of individuals think that they're doctors and nurses now because we have the internet. So I'm glad that you all
Yes,
do that.
they do.
I'm glad that you all steer them into the right direction, into those possible websites that are the best one for them to read and look on, like edus, .orgs. We want to stay away from .coms. Those are personal. Those are businesses usually, but they're not. They haven't been verified. So I would say edus, .govs. Is there any others that I'm missing? Jay, I know you're usually really good at this.
I'm sorry, you cut out for just a moment for me, so I missed the.
So I was saying the internet. So which internet sites should people basically go to get their information if they're going to do their own research? I say edus, .edu, and .govs. Was there anything else that you could add to that?
Yeah, I mean, I guess I wanted to reemphasize Dr. Tony's point about them coming back. I think that's a huge part of it. It's just we have to lower the stakes for people, and that's not any one community. It's for both rural and urban communities where the stakes are just too high. Like you get into a moment, you make a choice, and like there just shouldn't be the kind of consequences for one choice over another. And if you're in a community with a lot of resources, then yeah, you get to try things again. Like you get to mess up and it's okay, and you're going to get the support you need. And that's kind of what we want to build for everybody. Like I remember phones working. Does everyone remember phones working? Like they barely work now. And I don't know, I think like we have to give people some space. Like everything's like has to be so efficient, and we want to like get everybody through everything, but it's not a human way to deal with people. And I get it. When somebody doesn't want to listen to something that I'm saying is correct, like I get it. I don't expect somebody to change their mind in front of me. Like my job is to show that I care and to provide, what evidence I have, and to connect them with people who can help in the long run. And, that might change, and, maybe they only do 20% of all the amazing things that they should do to be healthy, and that's good. That's better.
Thanks for that. And you're right. That's what health equity is about, right, Jay? You were going into a really good discussion about that. How do we provide health equity, and how do our CHWs, how do we teach community health workers to provide that same health equity? From the association standpoint, what would you say that we do through the association to do that?
Well, I think just having people examine their biases and to work on their cultural competence is a huge part, but there's also a strength-based piece to it. That we work with a lot of students who might not know how beneficial they can be to their community. And so I think that's probably the biggest thing that we do at the association is just teach people that they can make a difference, and you can get the tools and you can build up your team so that you will have an impact, that you'll live better, and so will the people that you know.
I agree. Thank you for that. And Bishop Thomas, bringing you into that question, how will the Nevada Faith and Health Coalition work on health equity and kind of, trying to work on these health disparities within the African American community?
And so, well, that's a great question. And I even see a question that's in the chat as it pertains to providing oversight. What we're trying to do, as you know, Lisa, is number one, as I stated earlier, getting our communities involved in the process of being trained. And then number two, getting them within the local church community to assist the pastors with being able to, number one, first know. One of the first points of public speaking is to know your audience. And so we need to know the disparities, we need to know the challenges, we need to know the things that our congregation as well as our community are concerned about. We need to ask those tough questions. And so if we don't ask the tough questions, then what we as a faith community will do is assume that we know what's best for the people that we serve, as opposed to asking the simple question, how can I serve you? And I think that as a spiritual leader and a servant to the community, that should become every spiritual leaders' top priority. It needs to become our politicians' top priority. How can we serve you, and what are the needs in our community? And then go back and create the opportunities to provide whatever resource necessary, information necessary, from, as you stated earlier, hypertension and diabetes training and education, to just the open taboo conversation about sex. We need to make sure that what concerns the people becomes a great concern of ours. COVID has exposed that within our Black communities. People had, hesitancies and reservations about the vaccine. We went from vaccine hesitancy to vaccine resistance, and it's all because of fears and lack of information. Specifically, the Bible says people perish for lack of knowledge. So we want to make sure that we do our part in the faith community, but number one, first, becoming that trusted resource by having people that we've allowed to receive training and educate themselves in the area, from everything from Medicaid, mental health, first aid, just things that people need to know if we're going to be able to better serve the community which our churches are in. And so once again, I've taken a big leap to jump at the chest, of trying to get our churches involved in things that have been taboo in the past, from mental health issues. COVID has exposed that. COVID has brought about mental health challenges within our families and communities that people are not really talking about, and so I want to have the hard conversations. I want to challenge some that are on the line here, to hire community healthcare workers, number one, to learn about it, become one, advocate for it, and all of those type of things. And, so once again, this conversation is once again wonderful, absolutely necessary. And we just look forward to doing our part to make sure that people are aware, people know that they have a trusted source concerning information, somebody that they can trust, once again, with their, medical information. The faith community, as a pastor, is supposed to have a level of confidentiality. We're supposed to have an oath that we don't share, people's information. I know in the medical field, it's a Hippocratic oath and all that kind of stuff. But once again, sometimes people just don't trust, because of past experiences or whatever. So we're trying to make sure that the faith community has a trusted person, that people that have medical conditions, medical issues, if they don't feel comfortable speaking to, the leader himself, the leader has someone in their church and congregation that they can turn to and be a reliable source of getting correct information and pointing them in the direction that they can get the help that they need.
Thank you, Victor Thomas. That was really informative information. And you did my sales pitch for me, so thank you. I do want community health workers to be everywhere. Once I took the class myself, and it was like, hey, I do this work already. And then I really got into more of what community health was. I've just been a big advocate because I can see it. I can see community health workers being used in every area. When I'm at the grocery store, when I see police officers, I'm like, they need a community health worker. I'm always just pushing for community health workers. So I really appreciate that we have the faith-based community on board now. We know that other pastors were not, they did not know about community health workers or how they can utilize them in their church, because they typically call them volunteers, right? I've been a volunteer at Victory Baptist Church for, I think about 10 years. And I basically was a community health worker. Again, did not know that. So that's a wonderful thing for pastors, people in faith-based organizations to understand that their volunteers can be trained as community health workers and be able to help on a higher level, and a more healthcare level. So thank you for that. And Jerry, I wanted to ask you, as we talk about community health workers, and the reason why community health workers can even be billed for now is by the AB 191 bill that you came on board and helped with. I want to give a little background on that first before we get into that particular bill. I brought in former and late Assemblyman Tyrone Thompson. We miss him dearly. He was an advocate for the community. And also at that time, Senator Aaron Ford, he was a senator at that time. I brought him into my classroom at College of Southern Nevada while I was teaching community health work, just for them to be able to see what a community health worker was, because again, it was not known here in Nevada on that level. They then went back and created a bill. I actually don't have that bill number, but that was back in 2017, and it did not get passed at that time because, again, we did not have enough information. We had questions like, well, aren't they just medical assistants? Why do we have to certify this new field? Aren't they just this, or aren't they just that? The clarification of what community health worker and what they can do in all the areas they can work in was not there. Jay, you came in right in the nick of time to help with this new bill to help clarify that. Can you tell us that work that you did on that bill?
Yeah, I mean, that's quite the intro. So I started with the association in February, and this session happened in the summer, roughly, or right before the summer, right? I forget exactly what the dates are. So I just want to give a scale of the timetable. People have been putting the work in for 5 years before I started on it. I'm a process person, and so that's kind of the part that I got to help with and do. It's like we had the bill come out of committee after it had been explored, and both sides of the political aisle had decided what they were comfortable with trying. We had the research done on Dr. Tony's cohort of clients who were receiving CHW services, and it showed a $2 savings for every dollar spent on the program, which both sides of the aisle like that. And so it's like, okay, we've shown in Nevada, this saves us money. This is like, let's work on just the technicalities or the implementation of that. So AB 191 was actually drafted before I started, and I got to just represent it at the committee hearings and present what CHW work was, the history of it, and how an expansion of that would work in Nevada. And I know some of you might like the Medicaid rabbit hole. So there is your provider checklist in the chat. This one is specific to chronic disease prevention and management. So I just wanted to put that clarification. That does limit which doctors, physicians, APRNs, and nurse practitioners can bill and hire CHWs using that. We're available when legislators take a look at behavioral health for CHWs. So we're hopeful that that'll be explored by those officials in the next session. And so I've done some research ahead to show, yeah, it's going to save money in Nevada too. And it's also, a more humane way to serve people. It brings more power to rural communities that don't have any health centers at all. And then it also brings more voice to minority communities in our urban areas, which I'd like to throw out. We have a lot of minority communities in rural areas as well, but the language and the way HRSA looks at it, they kind of fund the rural communities and the urban diverse communities. So that's kind of how the language is landed. But there are so many new opportunities and ways of exploring what's possible. So I guess that was my role, was just to sit there and with the spreadsheets and the creativity and just kind of explore, like, what is this? Can I imagine this? And then can we explain it out? Can I hang out with people like Lisa to learn this history and how I can talk about these things in a way that'll be heard? And we have Cody Wagner, who's been teaching CHW classes for 4 years up in Fernley. And so he's just been a tremendous help in promoting CHW work and helping everyone understand what it is. And so I got to make pretty slides, and the rest is history. It had unanimous support.
So much, Jay. We appreciate it. No, but that was a really big deal to get that bill through, because it had been put up before and denied. So to even work on that and be a part of that, we appreciate it. The state appreciates it, and I'm sure organizations like Nevada Health Centers, now that they can be reimbursed back for their CHWs, appreciates it as well. Ms. Tony, I wanted to come back to you as we talk about this bill. How did this bill helped Medicaid come into the picture, right? And help organizations get reimbursed for the work that CHWs do. But you've been doing this work before this bill. So how were you paying CHWs before this?
Well, how are we paying them? We're paying them out of our pocket.
Exactly. I love that.
It's just that important to Nevada Health Centers. And I can tell you all the way from the top with our CEO, who is very vested in CHWs, taking a look at that. And we have 18 locations. Someone just mentioned rural and frontier sites where we would like to have CHWs in all of our facilities, that type of thing. So yes, it starts from the top. We don't get reimbursed for that service. That is something that we put in our budget. It's important. We can't have as many as we would like to have, but we're trying to figure out how that all looks as we start looking at our teams, our team-based care, et cetera. So again, with AB 191, as that's come out, and I know Medicaid is still trying to figure out a lot of things that are attached to that. So we think it's wonderful. And I see Bishop, I just got something in the email now from HRSA regarding the grant you were just talking about. So I believe it's all of those type of things that, help us as we move forward. And as a federally qualified health center, we are attached to HRSA in just a lot of things as a nonprofit organization, et cetera. But, our mission is to provide services to people regardless of where they're at, their ability to pay, et cetera. And again, it's important to us.
Thank you for that. That's advocacy, Ms. Deborah.
It is advocacy, absolutely.
It is. You're advocating for a field that wasn't here and didn't exist before, and now 5 years later is now has a section that can be billed for. But before that, you were advocating for these community health workers to work in this field without having any grant attached to it. I think that's important for other organizations to know. If you do not get Medicaid right now, if you're not signed up to be a Medicaid receiving agency, I should say, then there are other ways. There's lots of grants that are coming out. And I see your hand, Bishop Thomas. Do you want to talk about that grant?
Yeah, well, not necessarily the grant. I just want to talk about, when we start talking about disparities, I want to talk about how this particular opportunity is holistic. If we just deal with it with a family, somebody has a cousin, a grandmother, a brother, a father maybe, that they're already providing some care and services for, but they're absolutely doing it for free. They're doing it because it's a loved one that they love, but they really don't have any training on how to do that or anything. Once again, when you realize that a person can come and take a community health worker training class, get trained in an area, and then provide a quality of service to a loved one, relative, or friend that they're already doing, and then it becomes an employment opportunity, it removes a lot of stress, it removes a lot of tension, it removes a lot of problems that would normally exist for a person that's doing a job that they're not getting paid for, and they have the time now to do it because they're getting paid, and they don't have to worry about going to work and getting an income and then coming home and trying to care for someone that may be mentally challenged or physically challenged in certain areas. So community health worker training is very important on several levels. It is an entryway, for an individual to get involved in the medical field by getting exposed to, medical practices, policies, procedures, and processes. And it's, can be a lucrative career for someone that will go on to become a nurse or something of that nature. So the dynamic of the conversation, once again, is large, and it's not just talking about a specific community need, it's talking about the quality of life and quality of care for people that we say we love and are concerned about. And so it's a very, very, deep conversation. And once again, something that is long overdue with having.
Absolutely. And this has been such a deep and dynamic conversation that I hope a lot of organizations out there have just listened to and been able to take some information from to help get themselves some community health workers. I know Jay and I work, as you talk about workforce development, Bishop Thomas, that's exactly what you're talking about, is bringing this community health workforce into our city, into our counties. And Jay and I have been working with a lot of different minority organizations to bring community health workers that may not have even thought that you know, they could utilize a community health worker just because of the name itself. But we have to keep in mind all of the different names that are out there for community health workers. So Jay, can you speak on some of those, like the health disparity grant that you have and how you've helped a lot of different organizations, minority agencies and non-minority agencies get community health workers?
I think we're up to 17 on our piece. I don't know the total number from the state, but going back a little bit further, the state had this opportunity to apply to the CDC. And I think this is something we need to do more as a state. So we're not relying on all small organizations that don't really have the time to take the big risk and spend 8 weeks on an application that they may or may not get or often don't get. And then all the administrative paperwork afterward. And so with this CDC Health Disparities Grant, the state did talk to us early since we were doing the CHW education with them and asked us for help writing the application. I think they also reached out to the Office of Minority Health and many other stakeholders. And so we had this statewide approach when we applied at the CDC. And that increased the number of resources and the ability to get those resources out into the community. So for the Healthy Communities Coalition, we committed to hiring 50 CHWs. We're actually up to 53 without even doing a budget increase because a lot of them don't want to work full time. So it's kind of interesting how that all works out and can have such a huge impact. On top of that, our program isn't for every organization. And so of the 30 million that's available, the state can work with other organizations that might have more cash on hand so they can not have to do a reimbursement model, or agencies like the Cancer Coalition that are laser focused on a specific outcome that we want to improve in Nevada. And so it gets complicated, but I mean, if you get involved, I think the state, there's a huge learning curve, but the state's on that learning curve too. And so if you can all talk about that together, if you want help, meeting more like the Health Equity Office and the Office of Minority Health to get included in some of these opportunities, we all need to get to know each other better. Again, I keep saying we're a small state and we need to take advantage of that and be more impactful for our community, bring more grant funding, because Nevada pays more in taxes. I mean, I'm a broken record, but Nevada pays more in taxes than it gets back from the federal government. And that's just, absolutely. Yeah, I mean, it's not appropriate. I mean, we
missed out on a lot of grants. We've missed out on a lot of grants as a state because we have not worked together. So this is like a collaborative effort. I hope the pandemic has shown us that we all need each other. We all need to work together to get this work done, to also be useful to our communities. And one thing that I would like to say is that out of those 17 companies or organizations that you've worked with, Jay, to help them get CHWs, one of them is Silver State Equality, who actually is a civil engagement organization. They were one that I talked to on length about how they could utilize a CHW, because that was something that they did not think that a CHW could be useful for, because they thought, again, medical, public health, that's not what we do. We do civil engagement. They do LGBTQ plus work and helping endorse candidates, getting equitable candidates into office and things of that nature. Well, they hired their first CHW. And Mario, I've worked with him. He loves the work that he does. He did not know that he could even do this work. He actually came from another health organization and did not realize that he could do this work in a civil engagement organization. So that just goes to show that community health workers can be utilized in so many different fields and so many different areas in health, in faith-based organizations with Bishop Brown Thomas and his faith-based coalition, with Nevada Health Centers in a medical clinic facility with Ms. Deborah and Ms. Darylyn, and then at the association level, being able just to come and take the classes. So as we wrap up this conversation, because I know that time is waning, but this has been so good to me, and I hope good for everyone else and useful for everyone else. I just want to, Jay, I want you to talk about the association, how people can get registered to become a CHW, take the training, and then what their next steps are after that. And I see you put that Perfect. In the chat. Yes. Yeah,
so I have a link in the chat. So there is a registration link. I want to say we don't have an IT team or a tech team. So like our data coordinator and and I am trying to like build a system that is as easy as possible. So the classroom's doing really well. This registration automatic email doesn't send to you. So you'll get a personal little note saying we got it from you. I'd also like to say that we have had 240 students sign up for classes. So we've been putting out classes as quickly as I can. Elise has been helping contract some extra classes in there, and we've done 9 so far this year. There is still a wait list. The newest or the closest classes you can sign up to right now will start in June. And part of CHW work is, kind of breaking down this whole time thing. Like, if June will come soon enough, I promise you it's right around the corner. So if you sign up, it also helps us access more funding so that we can offer more classes and we can train more instructors to get all that out there. Let's see. On that, I guess a little bit about what is the class. So you go to a Zoom, and that's about 3.5 hours where you cover a couple modules. We show you what the online classroom looks like. And then for the next 7 weeks, you have some work to do online. So you log in and you chat with students on the forum, you read some different lessons, and then you turn in an assignment. And so you do that on a weekly basis for 7 weeks. And then at the end of the 7 weeks, you write out a case study. So you either take a real person that you've worked with and change the name, or you just kind of make up a client and you fill out all the assessment forms to see what kind of referrals they'll need, and the follow-up. Follow-up super important. It's one of the strengths of CHWs. So you do that piece, and then we have a final Zoom with some additional lecture, and you get to present your case study for 3 to 5 minutes. And at the end of that, then we do like the course evaluation so we can get all of our grant paperwork done, and then issue you an education credential.
So that's just a hybrid model, correct, Jay? A lot of people are confused by that. They're like, do I go to a classroom? They're like, do I get on Zoom and then go to a classroom? So I'm glad that you addressed that here. So it is the Zoom version first. It used to be in class, in person, in Southern Nevada and in Northern Nevada. But with the pandemic, we're now doing it on Zoom. Then you do the basically work by yourself as far as independent work, but we're still there for you as the instructors, answer your questions, things of that nature. And then you do it one last Zoom and present your actual case just to show that you learned everything that we would like you to have learned. And then you get your certificate. One thing that we would like to emphasize is that community health workers, now that the AB 191 bill has passed, can now be certified in the state of Nevada. And that is through the Nevada Certification Board. And that is just nevadacertificationboard.org. You can go to that and you can see what the credentials are that you would need. If you're a CHW1, I mean, you have not graduated high school, maybe you just took the class, you can become a CHW1. You do not need a high school diploma for that any longer. And then to be a CHW2, the credentials are on the website as well. You do need about 500 hours that you've worked in the field. You need a supervisor to actually sign off on you. And I know that I've been speaking to Ms. Deborah Tony about her CHWs and getting them to become CHWs too, since they've been doing this work already for the last 5 years. Ms. Deborah, how was the process for you?
Well, Darlene and I are steadily, we're still going through it.
Okay.
We started and filling out, all the information and that type of thing. So, so far so good. Darlene, what are your thoughts?
Yes, so far I haven't had any issues. We're a little bit on a standstill right now for some classes, but everything, the 500 hours, all of that, since we've been doing it for so long, has just been easy to submit and approve. I think once I've submitted all the information I needed, it was probably about 2 weeks for everything to get approved until right now that we're kind of on a hold, but it shouldn't be a long process if we've been doing it for so long to have everything sign off. And we do a lot of continued education through our company, our organization. So it's very easy to keep up with some of the stuff that you guys are requiring. So it's really nice. It's good. It's easy for sure.
I think certifications are important just to certify that people know what they're doing, right? And also it looks good, one, for their resumes as we build workforce development, but also to other companies to see that someone went through the process to actually become certified in something, just like a nurse or a doctor would, or a lawyer. You know, we want those people with those credentials. So thank you all for going through that process and working with us on the Nevada Certification Board. And then Bishop Thomas, to wrap everything up with the Nevada Faith and Health Coalition, I know you're looking for more pastors to get on board with this coalition. Can you speak more to that?
Absolutely. Once again, as we stated earlier, it's a matter of bringing correct information. So we want to make sure that pastors are informed of the opportunity now. And once again, we're talking about workforce. So this becomes an employment opportunity, you know, for ministries to have somebody that's on their staff, you know, that's an advocate for the congregation as it pertains to the needs of those individuals in which they serve. So I put our information, our personal email information in the chat. So if anyone wants to contact us, I believe Janet has a question, and I'm going to direct that to you, Elisa, as it pertains to Black-led faith organizations and civil rights organizations, justice organizations. How can they play, you know, a role in advocating for CHWs at a grassroots level? You've been doing it for a long time when you worked at the Urban League. We're doing it now, once again, with this particular coalition in the South. We'd like to expand that to anyone that's on the call that's up in the northern area as well, just so that, you know, this is not Las Vegas, you know, opportunity. It should be a holistic thing as it pertains to the state of Nevada. So churches and ministries that are in northern Nevada, you know, Sparks, Reno area, you know, all throughout Tonopah, wherever they may be serving their congregations, they need to get plugged into the opportunity, you know, of getting someone that becomes cultural competent concerning the people in the congregation that they serve, that gets themselves trained in knowing how to assist the congregation in advocating for their own medical needs. And so it's an exciting, but it's also a challenging thing, you know, to get out of the comfort zone, to get out of the four walls, and to, you know, get our head out of the sand and make sure that we're actually serving the people who God is entrusting to us.
And Bishop, that coalition is not just for pastors. It's for also the community and public health people, correct?
Absolutely. Once again, it is Nevada Faith and Health, and we're trying to bridge that gap. You know, we're trying to link, once again, those that are in need of services with those service providers. So we want to make sure that people have information to know how to do everything from get access to care to the senior that's having prescription challenges, and making sure that they're not struggling to, you know, choose between buying a meal or getting a prescription. You know, so these are things that we learned when we went through that class. I had no idea what a donut hole was, and it was really almost embarrassing and downright, you know, well, that's a whole nother conversation. I don't want to get on a soapbox, but to know that there is a challenge with a person that, you know, has a limited amount of resources, that has to, you know, struggle with getting medication, you know, it's a big problem in our community and society, and people need somebody to advocate on their behalf.
Exactly. And we appreciate what you're doing with the Nevada Faith and Health Coalition, and just bringing faith-based leaders into this work with us as well. Ms. Deborah, at Nevada Health Centers, are you all hiring community health workers at this time?
We are. I think we just hired on our teen pregnancy prevention CHW, who will be helping us with that program. Like I said, we've got some work we're doing with the city of Las Vegas to place some additional community health workers, and then our HIV prep coordinator, CHW. So yes, we do.
Need to have her come by our churches.
Yes. Yes. And Ms. Deborah has put her information in the chat as well for anyone that is looking to become a community health worker, or if you already are one and you're looking for work in Southern Nevada. I believe their Northern Nevada location also may be hiring. I'm not sure. Do you know about that, Ms. Deborah?
At our northern location, not at this. We just, I see my newest northern community health worker. I see her on this call. So,
yay! Good. I'm glad. No, but that is an organization that you all can keep in mind when you are looking for community health worker work. Also, as I mentioned, Silver State Equality and some of the other organizations, Mingle Health Solutions, that we've gotten community health workers at their organizations as well. And then with the Nevada Faith and Health Coalition, if you are a part of a church, tell your pastor about it, tell your bishop about it, and then possibly you can work with us through that coalition as well. So as we wrap this up, I wanted to see if there were any other questions. Ms. Janet, did you get your question answered through Bishop Thomas? I believe we did.
I did. Thank you, Alicia. I did. This was a great virtual. I learned very informative. I got a lot of good information. And we do have one of our members, our first vice chair, is actually going through the community health worker training here in Northern Nevada.
Perfect. Perfect. I'm so glad to hear that, because this is not just for public health or healthcare. This is for civil rights agencies as well, and organizations like the NAACP. So I'm glad to hear that you all will have a community health worker also. And then Jay, I see your hand.
Yeah, I wanted to just add a little bit. I know it's been a fire hose of information, but we've been building a space between the CHW and the CHW2 so that somebody can specialize. And the first one that launched is in early childhood. So our pilot cohort is going with the Children's Cabinet right now, and they've hired a full-time CHW manager specifically for CHW work in the whole state in early childhood. Get all the letters out. So EC, early childhood.
Yeah.
And so there's one more bit. We're trying to get CHWs into daycare centers and other services for new families. And there are another area of funding opportunity to open those new daycare centers. So just wanted to definitely plug that. We have another shared HRSA grant that is really launching that program.
No, we're really proud of that. I'm especially proud because that is my community health worker student. So any of my students out there, or any people that want to become my students at the Nevada CHW Association, you can get fabulous jobs like the one that we actually got for the person that's running that program for the ECC, early child care. Yeah, is it early childhood or early child care?
Children's Cabinet. So you weren't wrong about the extra C's.
Okay.
So early childhood and Children's Cabinet.
Yes. I called him up and I said, listen, there's this opportunity. You're a community health worker. And he's like, do you think I can really do it? And I said, absolutely. Because I'm one of those instructors. I watch to see who is doing great work, who has great questions. I'm just really fully in with my students, and I just watch and I pay attention. And so I keep those students in the back of my mind when opportunities come up, and this opportunity came up. And so now he is actually running a whole CHW program at Children's Cabinet with about, I believe, 7 to 8 community health workers. So it's a really great opportunity. And there's so many jobs out there now for community health workers because of this AB 191 opening up. So I want everyone out there to know, if you already have your certificate, don't get discouraged. There are jobs out there. Look on LinkedIn, look on Indeed, check with us, with everyone on this call. The association also posts jobs often. And I just wanted to leave any lasting words from any of our panelists. Do you have anything that you all would like to close up with?
Well, I just want to
mention one of the things that Bishop had mentioned, and that has to do with, and you mentioned it too, as far as health equity, and being able to train individuals in those areas, and what does health equity mean? When we start talking about biases and implicit bias, that everyone has biases. But again, you need to know how, what that means, because oftentimes people don't think you're talking about them, and they got all these biases and isms and all of that type of thing. They don't think that it's them, that they're talking about themselves. But the only way to help eliminate and reduce health disparities is to ensure that we're providing the same type of care, that we're opening things up so everyone has an opportunity to lead a great life. And I just want to say, for us, with our community health workers and the training that they receive, and then too, again, meeting people where they are. That doesn't mean that only Black folks take care of Black folks, Hispanic. It means that you have a level of knowledge so that we're making sure that we're not offending people. And I always use myself as an example. You know, back in the day when you would make them collard greens and you have that salt pork and all that kind of stuff in there, and it sure tasted good. But you can't just tell me I can't have that anymore, Bishop. I see you looking at me. I am using smoked turkey now. But again, working with Darlene and team, you know, one of the things she said is we've got to figure out a way for our Latinos to have some, what is it, tortillas. They just can't eat 100 of them. You know, so again, when people see someone that can relate to their culture, it's like, okay, she really does know what I'm talking about when I say, what I say about those neck bones and pork and all of that. Again, being able to meet people where they are and to provide them with the education and some training so that they know how sometimes these things may be detrimental to your health, especially if you got high blood pressure and all those type of things. But again, the whole piece with health equity and ensuring that everyone is receiving the same level of care.
Absolutely. That is definitely my business model, Minority Health Consultants. We're all about health equity and what that looks like, ending health disparities, and just bridging the gap between the stakeholders who want to do that work and those in the community. And Bishop, I see your hand up.
Yeah, I do have a final comment. As we talk about health disparities and health equality, the trusted source as a community healthcare worker, hopefully then we'll be able to gain the trust, you know, of clients and patients, so we can really get into the individualized medicine needs, which is really dealing with health research. If you have individuals that are not part of the process when it comes to understanding various diseases or whatever, and once again, I'm making this statement because going through the classes myself, understanding what COVID has done, when you have people that are hesitant concerning healthcare and all that, and they're not part of the process to figuring out how to come up with healthy solutions for everyone. I'll give you a good example. I'm reading an article and it says Alzheimer's is a big thing right now, but over 90% of the research is not done with any person of African-American, you know, culture or descent. So any result that comes, not having a person with this particular DNA involved in the research and the process might not work for me and my culture. So making sure that we have a trusted person in everything from being able to talk to them and advocate for bills and for things of that nature. But what about the actual medicine and prescriptions and things that are being given to individuals that have these challenges? If we're not part of the actual research that's taking place to get these medications into the care, then it's still going to be a little challenge with how we relate to the healing that needs to take process, you know, of us all. So thank you, you know, for taking the time to have this conversation. I pray once again that these individuals that have been listening, you know, we're taking into consideration the opportunity to do everything from hire to become part of the solution by becoming a community healthcare worker themselves. Thank you, Elisa.
Thank you, Bishop. You bring up a really great point about minorities getting involved in research. I have a colleague and a friend who started the Association of Black Researchers. Her name is Leonora Okora. And basically you can find them on Facebook. It's the Association of Black Researchers. And she did that for that specific point, to let people know, people of color know, it is okay and it's safe now to get involved in research and the reasons why we need to get involved in research, because if we don't have the data, we can't fix the problem, right? And so a lot of people obviously know about the Tuskegee experiment. And so a lot of people are hesitant about so many different things, COVID being one. They think this is an experiment, right? But also just any other thing that we talk about. And as we work with the Nevada Faith and Health Coalition on this particular grant with COVID and having community health workers go out there and basically educate and get information, give information to the communities about COVID, we don't want people to just be fearful of research. Research now has a lot of different things that it has to go through now to research on human beings. I just want you to know that I work with Dr. Melva Thompson Robinson at the School of Public Health at UNLV often, and she has a whole list of check marks that she has to do before she can even get human beings to be a part of even just, non-physical research. So I just want to, maybe take some fear away from people that are asked questions or surveys. We're not collecting your data and your information and selling it. It really is for research so that we can come out with the different medications and things like that you talked about, Bishop Thomas, and different protocols of what we do for specific communities. That's health equity. When we do everything as a blanket, that's not equity, right? Every community deserves its own piece of the pie, and how we work with them is different, but it's also culturally competent. And so I just want to take that fear away. Did anyone else have any closing remarks, or are there any other questions, Dominique, in the chat that we did not address?
No, it looks like we got everything.
Jay, did you want to leave any closing remarks? Or Darylyn?
I just wanted to add, as a community health worker, if you are thinking about going through the class, it's well worth it. I know that we've been doing it for 5 years, and we've come across different types of patients struggling through different paths of lives. And when you've given them the opportunity to get some kind of testing, either for free, because we've had other type of funding, or other organizations who are trying to get the same thing accomplished, just trying to make sure that we detect any types of cancers in early detection, and patients really appreciate it. Every race, they appreciate it. They know that we're there to help them anyway. We're not just, oh, here, just take the test and here's your result and call it a day. We don't leave you hanging. And it's really great when they say thank you, when they, if they've caught it early. Unfortunately, we've had a few, and they come back and they are very thankful that we've been able to assist them, and we still follow up as they keep coming to their PCPs. So we are a constant face for them, not just from the beginning, it's straight on through. And a lot of them still have our contacts information. And like I said, they call us for other things, appointments, refills, any information they want to get to their provider. They feel comfortable with us, and it's a great feeling for sure.
Love that testimony, Darylyn. Thank you. As representing community health workers, I want all of you out there to know, if you are a community health worker, you've been trained, and maybe you're not working right now, that you still have opportunities. There's more opportunities coming up. There's so many jobs that are coming up and opening, but just what Darylyn talked about, that's what you can give back to our community, is being that liaison for people that need us, right? For that trusted community. And so I encourage anyone out there that's not working as a community health worker right now, even if you have a job, maybe just get co-trained as a CHW, just so you have those skills. Bishop Thomas can speak to that. He's a bishop and running a Nevada Faith Health Coalition, but he also got trained as a community health worker, just so that he'll know what to do and how to do it. And I think that's a great model for all of us to kind of, go by. As we close this segment up of this Nevada Minority Health and Equity session, I just wanted to thank all of my panelists. You all were great. You provided some really great information. I hope that organizations and people themselves can utilize this information. And if there were no other further questions, I just want to plug that if you want any other public health information, you can listen to my show, Just the Facts, Public Health Just the Facts, on KCEP 88.1, first Mondays of the month at 9:30 a.m. This month, we will be talking about, in May, I should say, we'll be talking about holistic health. So please join us, and thank you all for coming.
Thank you.
Thank you.
You're welcome. Thank you.